first give you a little bit of context about the international health scene that we're thinking about, some information about the disease burden for women in particular. That's what I focus on. Some of the similarities and differences between breast cancer and cervical cancer, the two women's cancers that I've been working on for the last 20 to 25 years. Some specific information about cervical cancer, some of the challenges we face and some of the opportunities that are in front of us now, and similarly, some thoughts about breast cancer. And then just a few concluding thoughts, and I'm going to leave time for questions because I would really like to hear also what you're interested in about this topic and how it resonates with things that you already know about. So this is going to be one of these challenges on the split screen. This is the map of the world. And the question I wanted to raise here is, why do I focus on low and lower middle income countries? And the map shows you the dark green are the wealthier countries. And the yellow and sort of orange are the low and lower middle income countries. And these categories are defined by the World Bank. And the low income, well, that's part that disappears. So there's a hidden part between the two sides of the slides. So I'll tell you what it says, that low-income countries are defined by the World Bank as those countries where the average gross national income, the income per person, is less than $1,000, $1,025. So if you think about it, that's about $3 a day, a little bit less actually, $3 a day. That qualifies a country as low income. And lower middle income countries are those that have between $1,000 and about $4,000 a day as their part of their gross national income. So that tells you what those two income groups. And just by comparison, high income countries are those that have $12,000 or more per person as their gross national income. And of course, it does go up much higher than $12,000 for super wealthy countries. But that just gives you a sense of what the difference is that we're talking about between our lower middle, and high income countries. And also when we think about what that means in terms of how much is spent on health per capita, in a low income country, the average is $37 per person per year, okay? In lower middle income countries, it goes up to $90 per person per year. Whereas in high income countries like ours, the average is $5,000 per person per year. And that's a difference of 141 times higher for health. And that's an average for all the high income countries. I can tell you the United States is much higher than that. So we think about our focus at PATH, where I work, is on low and lower middle income countries, because these are the countries that have the fewest resources and often the highest health needs. So we're looking for solutions for them. So what are some of the main health worries that women have in these low and lower middle income countries? So I've got on this graph, and it's cutting it off, but I think you're going to be able to see what the primary problems are. But what I've listed here are the leading causes of death for women who are adult women aged 15 to 59. And this is in low and lower middle income countries. So up at the top, you can see that the one that is, well, let's see if you can see it or not. So the second green bar down, is there a pointer up here? Yeah, maybe. It's off the chart, is right. Let's see, is that a laser pointer? No, apparently not. Okay, we don't have a pointer either. So the second green bar down, which goes off the chart, is AIDS. So AIDS is one of the leading killers of women. But it's actually not the highest one. The blue bar, about 4 bars down, the blue bar that also goes completely off the chart, is for pregnancy-related complications. Okay, great. So the blue bar here is for pregnancy-related complications. And it actually outstrips AIDS by a little bit. Not by a lot, but by a little bit. And the second one, actually, that is after pregnancy complications and AIDS, is heart disease, which most of you probably wouldn't have thought was a leading killer of women in low-income countries. But in fact, heart disease and the next one down here, stroke, are major killers of women. This is women below the age of 60, remind me, okay? So, and the one that is actually in here that is just behind the first 3 is breast and cervical cancer, which is this one here, which is this pink one. And what I've done is I've shown breast cancer alone, which goes out to here, and cervical cancer, which is here. And when you combine those two women's cancers, it is out there with AIDS and heart disease and pregnancy complications in our lower income countries. And yet, in my field, I can tell you, you almost never hear anybody talking about women's cancer, because everybody thinks cancer is a problem of the wealthy world, when in fact that's not at all the case. So given this ranking of problems about how many people they kill, one wonders, and my question is actually over here, how much development funding does each of these problems get? So foreign assistance that goes to health issues from foundations and countries and multilateral agencies. So you can see some of the numbers. So HIV/AIDS, which is out here, gets $10 billion, almost $11 billion of aid each year. And that's not surprising. There's been a lot of resources, and it is a major killer. Tuberculosis, which is this top line here, gets $1.2 billion. So much less than AIDS, but it's also not as big a killer. And malaria, which we hear about a lot, gets $2.3 billion. Now, malaria is not a big killer of women. It is a big killer of children. And so that amount that it gets is related to the role it has in childhood mortality, but it isn't as big a killer for women. There has been a lot of attention to what we call safer motherhood, to try and reduce the complications of pregnancy and the deaths associated with that. And so that's now getting about $3.6 billion a year to help resolve some of those problems. That's all great. I mean, those are worthwhile things, important causes. All the remaining ones of these together, these are all considered non-communicable diseases. That's how they're lumped together, NCDs, non-communicable disease, heart disease, stroke, cancer. They all get less than $500 million a year, all of them together. So you can imagine that women's cancer slice, I can't even find the number of what goes to women's cancers, but I can tell you from my experience, it's very, very small. It's less than a few million. Okay, so that's one of the issues that we face. So why do we focus on women's cancers? One of the first reasons is because they're a prime example of the inequity that is happening between wealthy and poor, men and women, other issues. We see, for example, with cervical cancer, you can see this is a map of the incidence, the number of new cases each year, the rate of new cases per population each year of cervical cancer. And the darker the blue, the higher the rate. And you can see where the high rates are. They are not in North America, they are not in Europe. They are in Africa, Central America, and a little bit in the Central Asian republics, and India has kind of a middle rate. So you can see that more than 85% of the cases in the world occur in low and lower middle income countries. So that's a huge disparity of where cervical cancer occurs. When we think about this with regard to breast cancer, the story's a little bit different because the rates of breast cancer are actually still much higher in wealthy countries. So the number of new cases is much higher. But this is a map not of new cases, but of deaths. This is the mortality associated with breast cancer. And what is really shocking, and I think very unexpected for most people, again, the darker the color, the higher the rate. So the very dark red and almost brown red, those are the highest death rates from breast cancer. And look where they are occurring, in Africa. So rates are high also in Europe, in some places, and in the high-income parts of South America, for example, where we would expect. But nobody expects to see death rates that high from breast cancer in Africa. We also, the reason we see such high rates is because the mortality ratio, the number of deaths per case, is much higher in the low-income countries. Oh, so my graph is actually over here, and it's probably impossible for you to be able to see what it says now. So in America, the ratio of deaths to new cases is about 20 deaths out of each 100 cases. In Africa, it's about 60 deaths out of each 100 cases. And that's why we have such high mortality, comparable, even though we don't have as many cases, because 3 times as many cases die. And that's because women come late. It's because services for treatment aren't available. So this inequity is one of the things that really drives us to look at women's cancers. The other thing that is really pushing me and others who are working in this area is that the trends of what's happening are really concerning. The numbers are climbing because populations are aging. You have to live long enough to get cancer. And now that we are taking care of some of the things that killed women earlier, like childbirth and infectious diseases, they are living till their 40s and 50s, just in time to get cervical and breast cancer. So we're going to see the number of cases rise even faster, and the rates themselves are changing with breast cancer, not so much with cervical cancer, but the rates with breast cancer are changing because lifestyles are changing. And we know that lifestyles do have an impact on breast cancer. And so more women are moving to cities in low-income countries. When they move to cities, their diets change. They don't have access to the same kind of vegetables and fruits and things. Their activity level changes. They're not working in an agricultural setting. They may not be walking. They may be in a more sedentary lifestyle. All of those things affect one's breast cancer risk. And in addition, something that we wouldn't necessarily change is their reproductive factors are changing. So we know that if you start childbearing later, nurse fewer children, you have changed your hormonal profile and you increase your breast cancer risk. Well, we do not want to go back to the old way of having everybody pregnant at 12 or 13 and having 15 kids just to avoid breast cancer. So it's something we have to live with, but it's going to contribute to this trend that we're seeing. And the differences between rich and poor are actually growing. And I think we see that in all kinds of ways, this disparity between rich and poor. And that's going to have its impact as well on these cancers. So these trends are all in the wrong direction if we're concerned about women. And you can see this trend issue. This first graph here is breast cancer deaths. And the red bars are for the more developed countries, and this is 1990, this first column here. The red bar is higher than the blue bar, which is less developed countries. So there were more breast cancer deaths in 1990 in high-income countries. But by 2010, those poor countries had already surpassed rich countries. And by 2030, we see that that blue bar now is going to be twice as high as the red bar. That means there are going to be twice as many deaths from breast cancer by 2030, which is only 15 years, less than 15 years away. Yeah. This is the number of deaths. The vertical axis is the number of deaths. Raw number. So rather than rates. Yeah. And then the graph, which you can't see, was a comparable graph for cervical cancer, which is in the black in-between netherworld. And in that graph, we saw that the red bar is a very low bar because cervical cancer has not been a significant problem in rich countries for at least 40 years or so, 40 or 50 years. And I'll tell you more about that in a minute. But the blue bar on the cervical cancer is just going up, up, and up. So with these two women's cancers, and I'm not going to talk about ovarian cancer and endometrial cancer, they have much less frequent, much less we can do about them, and so we are setting them aside and really focusing on breast and cervix. And there are a lot of similarities between breast and cervical cancer, both obviously associated with women, but both also associated with stigma. Both have associations with sexuality, modesty, and both, because of cancer, are connected with fatalism. There are many, many societies, and this one, 50, 100 years ago, that believed if you got cancer, that was it. There was no point trying to do anything about it. So that kind of fatalism is still very dominant in most of these lower income countries. The other thing that is very similar between them is that the burden of disease and the priority accorded to women's cancer are underestimated, not only by global donors, but also by many countries themselves. They're not aware of what a significant problem it is. They don't have good health statistics to put this right in front of their faces. And so they make the same assumptions. Unless you're a gynecologist and you know that half the women in your gyne ward are dying of cervical cancer, if you're sitting in the Ministry of Health and not practicing, you have no idea that that's a big issue, and you're focused on malaria and childhood diseases and the things that the donors are interested in as well. So that's common for both of them. And another common thing, which I think our second speaker is going to maybe talk a little bit more about, is women's social position disadvantages them greatly, both from seeking care, especially preventive services like screening that aren't essential. They'll go for acute care, maybe, but the tradition is to prioritize your children over your own care. There is often not money to travel to health facilities or to pay the minor fees that may be involved. It requires taking time away from work and from your family. If you go to a health center, you may sit there for several hours waiting for your turn. They don't have appointment systems. And in some societies, you actually need permission from your partner, your spouse, or parent, some male figure. So these issues of social position are really important and will hinder care. And the other thing that's common between them, they both strike women in the prime of their lives, when they are in leadership positions, when they have still, their families are dependent on them economically. They often still have school-age children. We know that when the mother dies, school-age children usually drop out. So they have major ramifications, the fact that they hit now. These are not cancers that are coming in the 60s and 70s of life. These cancers hit in the 40s and 50s. Despite all these similarities, there are some differences too. One big difference is we know how to prevent cervical cancer through screening and other ways. We don't know how to prevent breast cancer very much. Some of the lifestyle factors can be modified. But we do know how to prevent breast cancer deaths. And that's where we focus. We can treat cervical precancer very easily. It's a 1 to 15 minute kind of treatment, and it's very cheap. When we get to treating breast cancer, it's much more complex and more expensive. But there are some options. We know low-cost solutions for cervical cancer. We've been at this for several decades now. It's less clear what the best solutions for breast cancer are. We have some more research to do. We have to try some things and evaluate them. So that's one of the differences, another difference between the two. I thought it would be helpful if we just try and put a human face on this and think about one woman's situation. And this woman was featured in a New York Times article in 2013, written by Denise Grady, who visited Uganda Cancer Institute, where we also partner with them on some work. The woman pictured here had noticed some lumps in her breast 4 years earlier before this picture. And she saw her doctor, who told her that the breast would probably have to be removed. And she said, well, I need to go home and think about that. Okay. So she planned to have the surgery after she thought about it and consulted with her family, but some friends and relatives talked her out of it. And they told her that it would just spread the cancer and kill her. And that's a belief that is widespread, that if you cut into a cancer, it will spread it. I've heard this in Ghana as well. So instead, she tried some herbal treatments. She went to a local healer, and her daughter had to take a loan out to pay for those treatments. So this is the financial burden on the family. And then, but the tumors kept growing, and her breast began to hurt so much that she couldn't stand it any longer. And she came back to the Cancer Institute at a time when a doctor from Seattle happened to be there. And the doctor, whose hand you can see, but whose face you can no longer see, did a biopsy on her, and they were able to determine that her cancer, in fact, had not yet spread. So she was very lucky and got surgery. But her story is so typical of what happens: coming late, getting misinformation, having cultural beliefs that prevent you from getting care, the cost to the family. It just highlights so many of those issues. So, is there room for optimism here? Well, for cervical cancer, I can say unabashedly, yes, there is room for optimism. This is a perspective piece that I was invited to give to the New England Journal of Medicine about 6 months ago, in June last year, with a lot of hope for what can be done for cervical cancer. So we have 2 opportunities to prevent cervical cancer. Nearly all cases of cervical cancer, as you may know, are caused by the human papillomavirus, which is HPV. And there are many types of HPV, like 100 different types, and about 15 of those are associated with cancer. But 2 main ones, and they're numbered mostly is how we talk about them, 2 main ones, type 16 and type 18, are the most common causes of cervical cancer, and several other cancers actually: anal cancer, penile cancer, and throat cancer. It's a virus that's very easily transmitted. It's mostly by sexual contact. And most people actually get infected at some point. I think CDC has estimated 70 to 80% of us will get it at some point in our lives. But the infection itself doesn't cause us any harm unless it persists. And we don't know fully why it persists in some people, and the rest of us have an immune system that's maybe able to get this virus off. So if it persists, and is allowed to continue to change the cells that it's in, that will eventually lead to a cancer process. And what we do when we are doing screening is we're looking for precancer, before it has become an invasive cancer. And in the precancer state, it's easily treated. So what we have basically, what we have part of up here, is we have a woman who is here, and she will pick up an HPV infection at some time during her sexual life. And if she's lucky, that infection will the body will reject it and heal, and she'll just go back to being normal. Never knows she had it, never had any problem with it. If for some reason that infection persists, it starts to change some cells. It can still heal itself and reverse and go back to normal without any intervention. But if it continues on from that persistent state, it goes to invasion into a lower level of cells. That's the part you can't see here, and it ends up in the box way over in the end there that says cancer. So there are a couple of things we can do to prevent this from happening. One of them is the HPV vaccine, and that vaccine prevents infection. So once you get the vaccine, like other vaccines, it prevents you from getting the HPV infection. And that's what we're all working towards, getting our girls, and in the US and a couple of other countries are also vaccinating boys. The other place where we can intervene is by screening, and we can intervene here between persistence and invasion. So if you screen, you're finding that pre-cancer, removing it, and then there's nothing to go on to cancer. So that's the importance of screening. So HPV vaccines really are the hope for our future to have the elimination of cervical cancer. If we get everybody vaccinated over the next generations, we have the possibility of seeing cervical cancer disappear. So there have been 2 vaccines available. Sorry you can't see more of that, but what you can see is this delightful little girl who's just thrilled to get a shot. This is in Vietnam, and then the bottom picture is in Uganda. So 2 vaccines have been available since 2006, so it's been 10 years already since these vaccines came on the scene. There is a new one called the 9-valent vaccine. It means it has 9 types of HPV in it that it protects against, that has become available since 2014. More than 200 million doses have been given so far around the world, and it's very safe, despite what you might read on the internet. It can protect against 70 to 90% of cervical cancer cases, depending on which vaccines you have. And one of the really good news pieces that we didn't fully expect was that it even protects some people who are not vaccinated by something we call herd immunity. And that means it reduces the amount of infection that's circulating, the virus that's circulating in the community, which protects even the people who weren't vaccinated. And it's herd immunity that we're trying to achieve with all of our vaccines. And so when we drop below a certain point of vaccine, you begin to lose that herd immunity. So things like measles that don't have to drop very far then burst out again. But we're really excited that we're seeing herd immunity with HPV vaccine. And our focus is really on girls 9 to 13, really to capture them before they become sexually active and get exposed to HPV. And Gavi, the Vaccine Alliance, is an international group that provides subsidies for vaccine to low-income countries. And so Gavi has been helping a lot of countries in Africa and Asia get access to this vaccine, which was very expensive. When it was first introduced in the United States, it was like $150 a dose, and you needed 3 doses. Well, now we know you only need 2 doses and still get good protection. And Gavi negotiated a price of less than $5 a dose so that they could extend their money much further, and poor countries could then eventually buy the vaccine for themselves. So vaccine's a really exciting story. Screening, we in the US were used to pap smears. So all the women in the audience know what that's about. Men might not know so much. 100 years ago, the rates of cervical cancer in the United States were very similar to what they are in Africa now. And because pap smears were introduced in the 1940s and gradually became more and more widespread, our rates have plummeted to 1/5 of what they were back then. But pap smears are expensive. They require microscopes and stains and glasses and trained pathologists, which is even more expensive. They're inefficient because you have to repeat them every year or 2 because they are what we call, they're not very sensitive. They miss positive cases. And pap smears miss about half. But if we repeat every year, it's a slow-going process, as I described to you. So if we repeat every year, then we will be okay. But it does require labs and trained pathologists. So we have some new options, which are over on the box you can't see. And those new options, there are 2. One is a vinegar test, which is called visual inspection with acetic acid. And you may remember acetic acid is vinegar. And we abbreviate that as VIA. And the other is an HPV test. So we know HPV is what causes it, so we can actually look for HPV whether it's there in the cervix. So these are two new options that we have. And VIA, the benefit of VIA is that it gives immediate results. What you do is a nurse or somebody who's been trained will swab the cervix with a little bit of vinegar, and they wait a minute, and that vinegar, that acetic acid, causes a reaction that will change the surface tissue to a white color instead of normal pink. And they can just see it with a flashlight or a good lamp. They can just see it. So you get an immediate result. And you can tell the woman right away, you're okay, or you need some extra care. You don't need a lab. Nurses can be trained to do it. It doesn't take a specialist doctor to do it. The materials are cheap. All you need is a speculum to be able to visualize a swab and a little bit of vinegar. But there are some drawbacks from it. You still need a gynecologic exam, which is a problem in some cultures, in many cultures. It's also a very subjective test. It's a matter of just looking. It's not really easy. It's not like there's a giant flag. It's a fine distinction that you're looking for. And it is also less sensitive. Like pap smears, it misses about half. But it has these big advantages. Now, if we look at HPV tests, the box over there that you can't see, HPV tests are very sensitive. They miss only 10 or 15%. They're very sensitive. And there are tests available now that require only a very simple lab equipment that could be sitting on a table in a small room with no particular other support around it. And they're automated, so they're not as subjective. So those are big advantages for HPV testing. But the tests currently cost $5 to $8 each. And remember back to what I said about the health budgets. $37 a person for the whole year. And we're talking about spending $5 to $8 of those dollars on this test. It's a big consideration for ministries of health. And the test itself takes several hours, so you can't give somebody immediate results. They have to come back and get their results, or you have to find a way to get results to them, which is a problem. One of the exciting things about HPV testing is that, did I lose something here? Oh, yeah, there was another exciting thing about HPV testing, an advantage that you can't see over there, is that the test can be done with a sample that a woman takes herself. So she can insert and take a swab and give it over to the health worker to be done herself. So the exciting thing about self-sampling is that it's very well suited to our low-income settings. It overcomes some of the health system barriers that we face. If we're short of health workers, the infrastructure, if we don't have enough room in the clinic, we have a project in Central America where the picture comes from, where they're handing out the sampling kits in markets and at community centers, and women just step into a private place, take their sample, come back out, and hand it over to the health worker. No need to visit the clinic at all if your test is negative, which it is for 80 to 85% of women. So it's a huge benefit when you can do self-sampling, because you can focus your scarce resources on the women who have a positive test. So, and it's culturally very acceptable. People thought at the beginning, oh, women won't want to do that. Doctors especially told us women won't want to do that. But then we ask women and they say, oh, that'd be so much better than what we have to do now. So it's been well accepted in all kinds of cultures. So when we think about screening, we always have to remember that if there's no treatment after the screening for the people who have a positive test, you wasted your time. So there is good options for precancer treatment. One of them is cryotherapy, which is freezing, and that's putting a freezing cold probe on the tissue that is infected, and that causes that tissue to be destroyed and kind of sloughs off. It's an easy process to learn. It takes about 15 minutes to do the actual treatment. One of the challenges we find is that the gas, the freezing gas, nitrous oxide or carbon dioxide, comes in these big tanks, which you can see here, that are very heavy, bulky, which means they're hard to move. You can't use them for mobile services. And they're hard to distribute out to health centers away from major cities. And sometimes they're very expensive, the gas. So that's a limit on cryotherapy that we are finding. Another technique, which I'm really sorry you can't see, is called thermocoagulation, and that's using heat to burn the abnormal tissue away. It's also an easy technique to learn. It takes less than a minute to do the treatment. The temperatures we're talking about are like 100 degrees Celsius, so it's not huge. And at least one of the devices comes with a handheld unit that has a rechargeable battery in the handle that will do 30 treatments. So very portable, easy to take, doesn't have to have continuous electricity. There's another type that's been around for a long time that does need to be plugged in continuously. But these are really good options for treatment. So we have lots of reasons to be hopeful for cervical cancer. We have safe, effective vaccines that are affordable with Gavi's help. We have effective and affordable screening tests for cervical cancer. We have treatment methods for precancer. We have simplified screen and treat approaches. It used to be that you had to have a biopsy before you did treatment. People determined that you don't actually need to do a biopsy before you do treatment. You should just treat, because you're going to lose women if you make them come back too many times. And we have a better understanding of the kind of messages that resonate with women and will get them to come in and take care of themselves. So these are all reasons to be hopeful with cervical cancer. Breast cancer is more complex, but there are reasons to be hopeful even with breast cancer. Rates will continue to go up, but we can improve early detection, and we can ensure wider access to basic diagnostic and treatment services. So is mammography a good option for breast cancer in our settings? If you're talking about a middle-income country that already has a little bit of equipment, then they should use that equipment for diagnosis first, and only later, if they get more resources, would they use it for screening. Because it's complicated to maintain quality mammography. But if we're talking about low and lower middle income countries that don't have such equipment, mammography machines cost more than $100,000 each. It's really not a feasible option for those countries. And so we're looking for other ways to do care. And so some very well-meaning groups in Europe and North America donate a mammography machine to a poor country. And they're not really doing them any favor. So we really want to encourage countries to think about solutions that are appropriate for their level. So we're doing a project in Peru called the Community-Based Program for Breast Health. And that program starts at the health center level down here at the bottom, where we are training community promoters to teach the community about being aware of breast symptoms when they should come in for care. And also teaching midwives who work in those community health centers how to do a proper clinical breast exam. And I'll tell you more about that in a minute. Then if a woman has a positive clinical breast exam from the midwife, she can be referred to a community hospital that is right in her neighborhood. And there, a doctor has been trained to use an ultrasound machine to see what that lump was, and also a fine needle aspiration biopsy, which is a simple kind of biopsy that's just done with a syringe and needle into the breast to pull out some fluid, and that can be sent the biopsy away to the cancer center rather than making the woman travel. So that's the second level. And then if her biopsy comes back or it's clear that there's a cancer, she can be referred to a cancer hospital. And in our project area, that cancer hospital is about 2 hours away. So this program has been put in place to try and make services more accessible to women so that they will come earlier. And the health promoters play a really critical role in building that breast awareness. We know that there's not very good evidence that suggests doing a monthly self-exam. We used to think that was really the answer for women to check their breast every month. It doesn't turn out to be that helpful. But an exam and being aware of the symptoms, which are pictured on the other side, that can be helpful. So what we have is a little chart of 8 breast symptoms that the health promoter goes out and educates the community with. And that will help women know when they should come in and encourage them to know that there's a midwife there who can tell them whether it's important or not. Most of the time it's not cancer, but they worry about it. So if they come in, the midwife can check them. And what we've done is train all the midwives to do a proper clinical breast exam, which includes taking a patient history, visually inspecting the breast to see if there are any irregularities in the skin or the shape, and then also to palpate or feel through the breast for any lumps. And it takes 1 day to train a midwife to do that properly and give her practice and supervision. And it's especially going to be useful in these countries where there's been very little screening, because women already have breast lumps in these countries where they haven't been screened. These lumps are bigger than the ones we hope eventually to get down to. So starting a program with a clinical breast exam will find most of the women who already have some cancer and can get them some help very quickly. So it can help in managing women who come in with symptoms, and it can also eventually become the screening approach that can be used. And it doesn't take specialists to do that clinical breast exam or ultrasound imaging or taking biopsies. We found general physicians are very competent at that. We have curricula to help teach them how to do that. We have a core group of Peruvian master trainers who are carrying out that training. And the National Cancer Institute in Peru has now set up a breast excellence training center. So they themselves are carrying this program forward. And of course, you have to adapt the health information system as well, because we're asking new services that aren't in their regular health information system. And so pictured here are 2 women who were identified in the project, got treatment with their, and on either side are their husbands and children. These are women who learned to recognize the symptoms based on what the health workers taught them. To be successful, you have to have women know what to look for, be willing to seek care, and have a health system that's able to respond to their seeking of care. Know that there's treatment that's going to be available and affordable. And Peru actually has an insurance program which provides cancer treatment for the poor. And palliative care for those where treatment is no longer possible, but they need pain management and other support. And those are the things that will help women survive breast cancer. So we need to put all those pieces together, from the community to the clinical breast exam to the tissue diagnosis to treatment and palliative care. And with that, we can build a sustainable model of care. So just a few concluding thoughts. One, the reminder that the women's cancers really are a significant problem, but underappreciated on many sides, especially in low-income countries. Early detection is good, and that's what we're striving for with breast cancer. Prevention is even better, which is what we can do with cervical cancer. There are solutions available. We need to tailor those to the resources that are available in our low-income countries. And that means human resources, financial resources, and the infrastructure that's there. If we put something realistic in, it's much more likely to happen than if we try to put in an ideal program. And one of the best cures for stigma and fatalism is to have more survivors. So, thank you. So we have about 10 minutes for questions before the break, and I'm happy to entertain any questions you might have.
We need to take mics around. So they can.
Oh, okay.
Here you go.
So
We're hearing challenged.
So Mike's heading your way if anybody has any questions. Or maybe I was crystal clear and you didn't even need the slides. Yeah. Yes.
This is Anne. Your coolness in the face of electronic glitches was very impressive. My question is it possible, because of finding these people who are ill, that many more cases are there and the statistics are possibly underestimated?
Yeah, we get that question a lot, and part of it comes back to where the statistics come from. Most of the statistics for global cancer come from an agency that's part of the World Health Organization. It's called the International Agency for Research on Cancer, and they're based in France. They put out this wonderful compendium of statistics called GloboCan. You can go online and find it if you want, and they make wonderful charts, but they know that the data, they can't rely on data from the countries because a lot of countries don't have this, and cases, like you say, don't even come forward. So they have several different ways of building models and projections, and they take into account data from neighboring countries, if that's better. They take into account who shows up in hospitals, and they figure, okay, if it's an area that didn't have a hospital at all, they probably have the same number of cases, we just don't have any reports of it. So they build those statistics around a combination of information rather than just, this is what showed up in the national statistics. So and they continue to refine them, they reissue them every 4 or 5 years, and as better data comes forward, they refine those estimates. So I think we can have a certain amount of confidence in the data, but yes, it is certainly possible that we're underestimating. But since they're projections, there's possible that they're overestimating in some way on some level. But we think these are the best numbers, and they're not just who walked in.
Okay, over here. Many cancers are associated with environmental factors. Does your work at all relate to that or coordinate with the environmental factors in the countries that you work with?
Yeah, I know that environmental factors are important for many of the cancers, less so for these two. Cervical cancer in particular has almost no connection, as far as we can see, with environmental factors. The few cases are, for example, personal environment, smoking, not great, but the impact of it is quite small on cervical cancer. Breast cancer, we understand less what the environmental factors might be for breast cancer. So for the two cancers that I work on, we don't get so much involved in environmental factors. I think for other cancers, they obviously have a much bigger role to play, and that would be important in that case. Yeah.
Yeah, this is Elaine Smith, and for primary prevention, I understand you're trying to get the vaccine out there and dealing with, probably with issues that we even deal with in the U.S. when you tell them their 10-year-old might be sexually active someday, and they're saying, no, you know. Then you have to take into account, well, their partner might have been, then you don't know who they're going to marry. But is condom use ever encouraged to prevent spread of HPV?
It is, and it's going to be encouraged anyway to prevent HIV and other STDs. One of the differences, and there is some partial benefit from condom use in preventing HPV, but the difference between HPV and HIV is that HPV is on the epithelium, on the skin, so it's everywhere. You'd have to kind of wear a wetsuit. Take some of the romance out of it. And so the benefit is not as much, and we're trying actually, because it's such a normal part of sexual life, that we're trying to destigmatize cervical cancer by saying it's not about promiscuity, it's not about those other things, it's just part of what's there in sexual life. So we don't emphasize it as much, and especially at the time of the vaccine, we're actually trying to de-emphasize the connection with sex. We're saying this is for the future, but we're trying to get these girls before they're even thinking about sex. So we wouldn't necessarily want to raise, and by the way, tell them to use condoms. So that we're trying to de-link those messages. Yeah.
Thank you for this. I'm in the sister study for breast cancer, and it's just the environment that is the main focus, it seems to me. There's hardly anything else that they're focusing on. So what do you think of that breast cancer, it's in the air or something? There are questions like, do you live by a busy street? Do you have a clock in your room at night? Do you live on a golf course? Things like that.
I think that that's really just part of the the discovery effort, we're trying to understand what causes breast cancer, and we are so far still in the dark. We know that there are many different kinds of breast cancer. I mean, this is the other thing. Is it actually really just one disease? Because we know that there are ones that are hormonal sensitive and ones that are not, ones that occur after menopause, ones that occur before, and they seem to have different outcomes. They respond to different treatments. I think that what perhaps the study you're part of is just an effort to answer the question that the gentleman over here asked. What are the environmental factors? We don't know. And they're trying to find out, and they want to cast a pretty broad net to see what those factors might be, because breast cancer is such a huge problem in this country especially, and in others as well, that if we found something that accounted for even 10% of breast cancers, and we could do something about it, it would have a huge benefit. And doing public things around the environment are much easier than asking individuals to somehow change their behavior. So I think it's just, my guess is that it's just part of the discovery process. People are trying to learn and understand. We know some of the hormonal factors already. We don't need to keep researching them. We're trying to understand what are some of these other factors that are also at play.
My turn. Hi. On some of your earlier charts and maps, it showed that cervical cancer was low in the Middle East and North Africa, and then there was a later one where China had wasn't. How much of that is non-reporting, and or are there reasons why they had lower rates?
Yeah, I think that the Middle East, there's a band across, from the Middle East across to about Pakistan that has lower rates. Now we don't understand fully why. It may be something different about the HPV types that are there. It may be partly different to the fact that men are circumcised. We know that circumcision makes a difference. That it may be related to women's less exposure, because women's sexual behavior is much more conservative in those settings, as far as we know. So we don't fully understand why, but it is true that the rates are lower in that band. China is a little bit different story. China is such a huge country. There are parts of central China that have high rates. And then there are parts on the coast that don't. And when you average that across 1-point-something billion people, the average rates come down. We see the same thing actually in Vietnam. The north of Vietnam has relatively low rates of cervical cancer. The south has rates that are 4 times higher. And when you average them together, it looks like it's not a big problem in Vietnam, but there are pockets where it is. So we don't fully understand all the reasons for that, but it's a very interesting issue. Yep.
Other questions? Okay, thank you very much. We'll take a 10-minute break.
Thank you.